This is an introductory session on palliative care sponsored by the California Healthcare Foundation. Specifically, we'll be talking about how palliative care helps to bridge the gaps in the healthcare system for seriously ill Californians. My name is Ann Kinderman. I'm a physician and director of the Supportive and Palliative Care Service at Zuckerberg San Francisco General, which is the safety net hospital for San Francisco and northern San Mateo counties. I'm also an associate clinical professor of medicine at UCSF. The objectives of this session are to deepen your understanding of palliative care, what it is and what it isn't, where it's provided, who provides it, how it's related to hospice care, and how it impacts patients' care. My hope is that you'll be able to describe the development of palliative care in the United States, and then to specifically discuss the development of palliative care in California. We'll also talk about some state initiatives for Medi-Cal patients, which is California's state-run Medicaid program, and specifically talk about some legislation known as Senate Bill or SB 1004. Many times, when a patient faces a serious illness, the patient might feel like they're lost. Something like this picture. It's kind of foggy and hazy. You may or may not know where you ultimately are going, and if you do know, you may have a hard time finding your way there. This is true not just for the patient, but also family members, friends, and caregivers. In this journey, patients often experience distressing or uncomfortable symptoms. Patients also might get confusing or conflicting information about their conditions, and there might be significant uncertainty about the future. In addition, serious illness often raises big, sometimes existential questions like, why is this happening to me? Or, what does this mean? There's also often a significant social and financial impact of a serious illness. And then, on top of everything else, you have to face the complex healthcare and social service systems. In this hazy, uncertain territory, palliative care acts as a bridge. Using a similar analogy, the Center to Advance Palliative Care has developed a brief informational video describing palliative care to a very general audience. It describes the patient or the person as a bridge, and palliative care as the supports underneath, as the bridge experiences stress from serious illness. Palliative care helps to support that bridge. Palliative care provides an extra layer of support for the patient and family facing serious illness, but what type of services does it include? Symptom management is one of the core components of palliative care, addressing things like pain, shortness of breath, constipation, or fatigue. Palliative care also helps to provide information about prognosis and treatment options. It helps to address the values that a patient and family has and translate those core values into medical choices. Palliative care as a core component also includes spiritual support and psychosocial support. Given that variety of services, who provides palliative care? Most commonly, palliative care teams include nurses, physicians, social workers, and chaplains, forming a truly interdisciplinary team. Other palliative care teams might include psychologists, pharmacists, rehabilitation specialists, patient navigators, or community health workers. It's also important to note that palliative care is not only provided by subspecialists, but also by primary and other specialty care providers who are caring for people with serious illness. This is what we call primary palliative care. If you need palliative care, where can you get it? Palliative care is most prevalent in hospitals across the United States. As of 2015, according to the Center to Advance Palliative Care, 67% of all hospitals larger than 50 beds reported providing palliative care. Palliative care can also be provided in clinic settings. Sometimes palliative care practices are standalone clinics, but they can also be co-located or embedded with other specialty clinics, such as oncology or cardiology, or embedded with primary care. Palliative care can also be provided in private residences or homes, and is often delivered by home health or hospice agencies or standalone palliative care programs. Finally, palliative care can be provided in extended care facilities such as assisted living or skilled nursing facilities. One question that comes up, particularly for healthcare providers, is when patients should be referred for palliative care. Palliative care is appropriate for any patient with a serious illness who also might need help with clarifying goals of care or understanding patient or family values, if the patient has burdensome symptoms, psychosocial or emotional distress, existential or spiritual distress, is preparing for the end of life and has difficulty coping, or has a caregiver who's experiencing significant stress. Since palliative care is a relatively new field, there are many misconceptions about it. One of the common misconceptions is that it's only for cancer patients. While it's true that many patients with advanced cancer are often referred for palliative care is appropriate for patients with any type of serious illness. Sometimes people confuse palliative care and geriatrics and think it's only for elderly patients. In reality, palliative care can be provided to infants and children, young adults, middle-aged adults, and the elderly, really at any age. Some people think that palliative care is only for terminally ill patients, when in fact, palliative care can be provided at any point in the trajectory of a serious illness and is often recommended to be started at the time of diagnosis, well before the terminal phase of illness. Because palliative care focuses on relieving suffering and improving quality of life, sometimes people think that it's only for patients who want comfort measures only. In fact, the majority of people who are receiving palliative care, at least initially, are pursuing life-prolonging treatments. Lastly, and probably most commonly, people confuse palliative care thinking that it's the same as hospice care. This diagram helps to illustrate the relationship between life-prolonging therapy, hospice care, and pain management. As you can see, life-prolonging therapy and hospice care usually do not overlap. By contrast, there's a great deal of overlap between palliative care and life-prolonging therapy, and palliative care and pain management. This diagram also illustrates that hospice care is in some ways a specialized form of palliative care for people who have limited prognosis and whose goals are exclusively focusing on comfort. Although palliative care addresses symptoms of pain that are associated with a serious illness, it usually does not include chronic pain management. Now that we've talked about the basics of palliative care, let's talk about what we know about the impact of palliative care. There is a substantial body of medical literature which addresses this subject, and there are way too many references to be included on any one slide. These studies, taken as a whole, demonstrate that palliative care improves patient and family satisfaction, reduces symptom burden, improves the efficiency of healthcare delivery, and reduces overall costs, and in many instances, even prolongs life. Because of this, many providers have said that palliative care is actually the perfect example of meeting the triple aim of improving health, lowering costs, and providing better care. So in summary, palliative care is appropriate at any age and at any stage of a serious illness. It's provided alongside disease-modifying treatments and is most effective when offered early on in the disease course. It's effective at improving patient and family's care experience and reducing unnecessary costs, and serves to provide an extra layer of support. Importantly, it's related to but separate from hospice care. Now that we've talked about the basic principles of palliative care, let's look more specifically at palliative care in the United States. One of the major catalysts for the development of palliative care in the United States was the release of this landmark study in the Journal of the American Medical Association in 1995 called the SUPPORT trial. This trial looked at the care of patients hospitalized with 9 major illnesses, looking at the care across 5 major medical centers in different geographic regions in the late 80s and early 90s. Based on their observations, they found that patients' preferences were often not documented. Many patients died in the hospital, often with their preferences recognized very late in their disease course, and the patients had a significant burden of pain as they approached the end of life. About 20 years later, the Institute on Medicine released the Dying in America report in 2014. This group found that provider education in palliative care has improved substantially, but there are still education gaps both among the general public and among healthcare professionals in understanding the role of palliative care. The report also highlights that there are not enough trained hospice and palliative medicine professionals. For these reasons, the panel encouraged the creation of communication standards, payment structures, and programs to improve advanced care planning. It also encouraged the expansion of palliative care training opportunities, both for primary and specialty palliative care, and encouraged the integration of paying for medical and social services and care coordination. This chart, developed by the Center to Advance Palliative Care, addresses the prevalence of palliative care programs in hospitals across the United States based on hospital size and ownership. As you can see, for the larger hospitals, over 300 beds, palliative care services are very common. But in smaller hospitals with less than 50 beds, palliative care is far less common. You can also see that there are differences in the prevalence of palliative care based on hospital ownership. For-profit hospitals are far less likely across all hospital sizes to report having palliative care services. Another way to look at the development of palliative care in the United States is to look at the prevalence of palliative care by state. In this figure developed by the Center to Advance Palliative Care, you can see the prevalence of palliative care by state in 2015. States in the red received a D grade and had the least prevalent palliative care. States in the blue had the most prevalent palliative care and received an A grade. Overall, in the United States, we were given a B grade, with 67% of hospitals over 50 beds reporting palliative care services. This schematic shows the services that are widely available today for patients with serious illness. At the point of crisis, hospital palliative care is often available to address patients' and families' needs, particularly if that hospital has more than 50 beds. Additionally, patients can receive home health services and sometimes case management to help deal with all of the confusing and burdensome aspects of serious illness care. When patients are approaching the end of life, if their goals are particularly focused on comfort, then hospice services are widely available. However, there is a significant divide that prevents the smooth transition between treatments on the left side that are often provided with disease-modifying therapy and end-of-life services provided by hospice. Recognizing the divide between the services typically provided alongside disease-modifying therapy and end-of-life care provided by hospice, several systems across the United States are developing best practices in integrated care, providing smooth transitions from the time of diagnosis through end-of-life care. In these programs, from the time of diagnosis, patients are offered a variety of supportive services. Early on, they can receive care management and home health services if they're homebound. Later on, if the symptoms are difficult to control or there are other unmet needs, patients are referred to specialty palliative care services And then as they're approaching the end of life, if their goals of care are appropriate, they're referred for hospice services in a seamless way. In these systems, there's an emphasis on training frontline providers in primary palliative care, including advanced care planning, symptom management, and psychosocial support. As symptoms and consequences of serious illness progress, patients are then seamlessly referred for palliative care and later hospice services. Sometimes, the time course from diagnosis to end-of-life care is quite short. For example, if a patient who is previously healthy has been diagnosed with a widely metastatic cancer. In these situations, many professional organizations have recommended automatic specialty palliative care referral right from the time of diagnosis. Now let's take a look at a couple of examples of community-based palliative care. An example of clinic-based palliative care is the symptom management service at UCSF. The clinic is co-located with a variety of oncology practices in the UCSF Cancer Center. Referrals are made in two different ways. They can be initiated when needed by oncologists in the cancer center, or they can be automatically triggered by a specific diagnosis or prognosis. What they have found is that when patients receive palliative care at least 3 months prior to the end of life, that the end of life costs for these patients are significantly reduced. They've also found a statistically significant improvement in a variety of quality measures associated with cancer care, such as the number of emergency department visits or whether or not patients had an ICU stay in the final days of life. Another example of community-based palliative care is a home-based palliative care program called the SHARP Transitions Program. SHARP Healthcare is a not-for-profit integrated healthcare delivery system in San Diego, which includes acute care hospitals, specialty hospitals, medical groups, and a health plan. The Transitions Program has 4 main pillars: home-based palliative care consultation, evidence-based prognostication, caregiver support, and advanced care planning. They enroll patients who are diagnosed with cancer, heart failure, COPD, and dementia. Their main outcomes are that patients have a high degree of satisfaction. 88% of them would recommend this program to friends or family in a similar situation. They've also noted substantially lower costs among Transitions program, about $3,000 to $5,000 less per patient per month across all disease groups enrolled in the program. They also observed improved quality, with about 3/4 of patients reporting significant improvements in their quality of life, as well as increase in hospice use and longer hospice length of stay compared to their control groups. To summarize what we've discussed about the development of palliative care in the United States, palliative care has undergone rapid growth in the last 20 years. It remains most prevalent in hospitals, though it is expanding rapidly in the community, most in home-based programs and clinic-based programs, and is the least common in extended care facilities like skilled nursing facilities. There remains disparate access to palliative care depending on hospital type and size, and there is significant evidence of improved outcomes with the provision of early palliative care, particularly in the community. Now let's take a look at the development of palliative care in California. Similar to the Institute of Medicine, in 2016, the California Healthcare Foundation and the Coalition for Compassionate Care of California joined forces to produce a report called Dying in California, a Status Report on End-of-Life Care. This report was a follow-up to their baseline findings in 2006. It demonstrated that over that 10-year period, there was a significant expansion in access to palliative care through the development of new palliative care programs. It also showed that there were some innovative partnerships between payers and providers, which supported new ways to deliver palliative care outside of traditional payment mechanisms. The report highlighted some system-wide advanced care planning initiatives across different types of healthcare delivery systems, from commercial systems to public health systems. The report underscores some of California's strengths, which include centers for education and leadership and some major public policy initiatives which have contributed to the development of palliative care. In addition to the Dying in California report, the California Healthcare Foundation funded the Palliative Care Mapping Project in 2015. This project addressed the question of whether there was sufficient access to inpatient and outpatient palliative care to meet the needs of seriously ill Californians. The need for palliative care was conservatively estimated based on the number of Californians dying of a variety of chronic illnesses who would be most likely to need palliative care. The estimated volume of patients who would need palliative care in a year was then compared to information collected on all of the identified palliative care programs in the state. The map on the left shows the estimated sufficiency of inpatient palliative care, or the reported capacity of identified palliative care programs relative to the estimated need for palliative care. This report showed that there were 19 rural counties in California with no access to inpatient palliative care services, and there were only 2 counties which were able to meet at least 3/4 of the estimated need. Overall, the existing 186 programs could only meet 40% of the estimated need for palliative care. In terms of the need for community-based palliative care, the map on the right reveals that 22 counties had no access to community-based palliative care, and only 3 counties had enough capacity to meet at least 75% of the needs. On average, the 189 community-based palliative care programs would be able to serve less than 30% of the estimated 184,000 Californians every year who need palliative care in the last year of life. Although access to specialty palliative care is currently insufficient, there have been some key initiatives to expand access to palliative care for vulnerable populations. The Partners for Children initiative allowed children with serious illness to receive concurrent hospice and life-prolonging treatment, enabling children and families to have improved quality of life while still reducing the overall cost of care. The California Healthcare Foundation has also funded 2 key initiatives to expand access to palliative care in the California safety net. Because of these initiatives, all 17 of California's acute care safety net hospitals now have palliative care services, and many are also now developing community-based palliative care services. California is also striving to address the workforce shortage in palliative care through several learning centers, including the California State University's Institute for Palliative Care, which provides a wide array of online trainings, and the UCSF Palliative Care Leadership Center, which supports the development of specialty palliative care programs. And as has been highlighted several times in this presentation, 2 key leaders in advancing palliative care in California are the California Healthcare Foundation and the Coalition for Compassionate Care of California. Beyond expanding access to specialty palliative care, there have also been a number of important public policy initiatives in California. In 2012, Governor Jerry Brown initiated the Let's Get Healthy California Task Force. This group was tasked with developing a 10-year plan to make California the healthiest state in the nation. Interestingly, palliative care and end-of-life care in particular was identified as one of 6 major areas of focus to help achieve this goal. In addition, the California State Innovation Model, or CalSIM, also highlighted end-of-life care. In 2012, California was one of many states to apply for funding from the Centers for Medicare and Medicaid Innovation to jumpstart the redesign of healthcare systems following the implementation of the Affordable Care Act. The CalSIM provided the means for implementing recommendations from Let's Get Healthy California and leverages public policy, payment reform, and private sector initiatives. Regarding end-of-life care, the CalSIM has a work group dedicated to evaluating the state's progress toward the goal of maintaining dignity and independence at the end of life. Whole Person Care and Health Homes are two programs which focus on improving care for Medicaid patients in California who have been identified by health systems or insurers as having high utilization of healthcare services. These programs focus on the integration of health, behavioral health, and social services for these populations. Both initiatives emphasize identifying patient-centered care goals and care coordination, two core components of palliative care. Since patients who are eligible for these programs often experience a high burden of symptoms and may be approaching the end of life, integrating palliative care will be an important component of the care that is delivered. Finally, California lawmakers have recently passed key legislation to develop a POLST registry and in 2015 legalized aid in dying through the End-of-Life Option Act. Senate Bill, or SB 1004, was another key piece of legislation in California, which addresses services for Californians covered by Medi-Cal. It was signed into law in 2014 and mandates access to palliative care for patients enrolled in managed Medi-Cal plans. It requires that the Department of Healthcare Services provides guidance for patient eligibility, standards for palliative care, and technical assistance to the managed care plans. The law requires that services provided under SB 1004 remain budget neutral. This is a schematic developed by the Department of Healthcare Services to illustrate the relationship between SB 1004 palliative care and other services provided to seriously ill Medi-Cal patients. Based on reviews of successful community-based palliative care programs, SB 1004 palliative care is intended for patients who have advanced illnesses but who have not yet reached the terminal phase of illness and are therefore not eligible for hospice services. Although the state encourages the provision of early palliative care from the time of diagnosis, this early palliative care is not required under SB 1004. This illustration reinforces that palliative care is provided alongside disease-modifying care or curative care. As of December 2016, the Department of Healthcare Services has provided some preliminary information regarding which patients will likely be eligible for SB 1004 palliative care. First, there are some general eligibility requirements. Patients must be in the late stage of illness and would be expected to decline in the next 1 to 2 years. Patients must have received or been offered appropriate disease-modifying treatment. And lastly, the patient or family must be willing to engage in advanced care planning activities and engage with the palliative care team prior to seeking acute or emergency care services. In addition, there are disease-specific eligibility guidelines for patients with heart failure, COPD, advanced cancer, and liver disease. Based on mortality data reported by the Department of Healthcare Services, 52% of Medi-Cal patients die as a result of one of these 4 conditions and would potentially be eligible for SB 1004 palliative care. As of December 2016, preliminary information released by the Department of Healthcare Services suggests that a set of 8 services will be required under SB 1004 palliative care. These services include advanced care planning, palliative care assessment and consultation, development of a plan of care and then communication of that plan, pain and symptom management, mental health and medical social services, care coordination, an interdisciplinary palliative care team, and specifically chaplain services. Although not required, 24/7 telephonic palliative care support is encouraged, as this has been found to be a key component of many successful community-based palliative care programs. To summarize the development of palliative care in California, access to specialty services has been expanding, though currently is still insufficient. There's been innovation in many areas, including approaches to advanced care planning, new payment models, local coalitions across the state, and new programs targeting vulnerable patient populations. There are also several Medi-Cal initiatives which involve palliative care and will likely help expand access to these vulnerable populations even further. This concludes our introductory session on palliative care. For more information, visit any of the websites listed here.